interventional electrophysiologist, so normally I like to talk about ablations. However, the task that was given to me today is actually talk to you about whether we should be abandoning our old friend Warfarin in favor of the not so new direct oral anticoagulants, and whether Warfarin still have value to give us or add. Now, some statistics were presented by Dr. Estes, so we know that the prevalence of atrial fibrillation is increasing with increasing age, and it's more in the elderly population and common in heart failure patients. We know it's not a benign condition. It's actually serious. It's associated with double the mortality compared to patients with normal sinus rhythm. And the most feared complication or morbidity, of course, strokes, which in non-valvular atrial fibrillation constituted 2 to 10% per year. However, this risk is much, much higher in the elderly population. And in patients with rheumatic atrial fibrillation, that risk is 5-fold more. In addition, the strokes that you get with atrial fibrillation are more devastating and also associated with significant mortality. To set the record straight from the beginning, when we talk about non-valvular atrial fibrillation, sometimes there's confusion about what is non-valvular atrial fibrillation. So I put this slide, and there are a little bit difference between what the ACC, HRS, and the European will say about what's valvular atrial fibrillation. In the other side of the Atlantic, in the US, mitral stenosis, mechanical or bioprosthetic valves, or mitral valve repair patients actually considered valvular atrial fibrillation. In the AC guidelines, there is no mention for the mitral valve repair. We also know that our NOACs are not to be used in patients who undergo or who have mechanical valves. Those are the results from the dabigatran trial, and in this study, which was actually discontinued prematurely, dabigatran actually was associated with increased strokes and bleeding, so it should not be considered for those patients. Now, everybody now, whether the Europeans or the Americans now using for guidelines the CHA-MS score for risk assessment. And I think the utility of this score actually is more important when you're talking about people with lower risks. For example, with a CHA-MS 0 risk, your actual score, your risk is almost 0 to get thromboembolic events. Whereas in the old CHA-MS score, if you have a 0 score, you still have you are at a smaller risk. So everybody now uses the CHA-MS score for risk assessment. Now, we have used warfarin for a long time, and it's effective. It does reduce thromboembolic events by 2/3. However, everybody knows about the challenges that we face with that drug. It has a low or a narrow therapeutic range, lag to effect, and need for regular checks, along with interactions with drugs and medications. Now, that would lead to low adherence rate and difficulty to maintain to actually maintain therapeutic levels. And actually, in the prior studies, less than half patients who were candidate for this therapy were getting it, and even the patients who were getting warfarin, half of them actually, or less than half of them, were in therapeutic range. So now we have those new guys on the block, the NOACs, whether it's direct thrombin inhibitor like dabigatran, or the factor 10A inhibitors like rivaroxaban, apixaban, and indoxaban. Actually, they have very stable pharmacokinetics, and therefore they have a simplified dosing regimen. They do not need monitoring, and they have less interactions with drugs and foods and drugs. And above all, the clinical trials showed them to be actually at least non-inferior to warfarin in reducing thromboembolic events, and actually safer. I'm not going to fully review the trials, but I'll just discuss the main points. Those are the patient characteristics for the 4 trials that are phase 3 trials for the 4 agents. We have Aristotle for the apixaban, Relay for dabigatran, Rocket AF for rivaroxaban, and Engage AF for endoxaban. There are some differences, so the population is not exactly the same. And when you're talking about the mean CHAD score, the Rocket AF had actually the patient with the highest risk. The rest were a little bit lower. If you're looking at the target time in target range for the warfarin groups, they mainly were in the low 60s, mid-60s, but the Rocket AF, rivaroxaban, they were in the 55 range. Those are the primary outcome. When you're talking about ischemic strokes, all those drugs actually were non-inferior to warfarin. And in the case of high-dose dabigatran, we had 2 uses for dabigatran. I'm using the mouse, but apparently there is no mouse there. Sorry. Okay, here it is. It's actually superior to warfarin with the higher dose of dabigatran. The more important thing is actually the safety of those drugs, with the major bleeding, and specifically intracranial hemorrhage and fatal bleeding less than half with those agents. And actually, if you look at meta-analysis, so if you take those drugs as group, you will see that those actually results are very valid. There is less ischemic strokes and definitely reduced risk for hemorrhagic strokes. There is no increase in myocardial infarction and improvement in mortality, in survival. We talk about intracranial hemorrhage and GI bleed. The GI bleed seemed to increase with those drugs. You see how the improvement or decrease in intracranial hemorrhage compared to actually there is a 25% increase in GI bleeding with those drugs. And probably among the drugs, probably the most one associated with the increased GI bleeding would be probably the high-dose dabigatran. The least seemed to be apixaban. So the trials were good for the NOACS, but we want real-life data. And I think, like Dr. Estes mentioned, the registries add a lot of information how to treat our patients and our practice of anticoagulation in patients with atrial fibrillation. And discuss other things that we'll go through. Does really one size fits all? And what about compliance? There are no blood levels to check, so how we can assure that? And what about patients with kidney disease, which is actually important topic in this type of drugs? And drug interactions would continue to exist, actually. And what about reversal agents? What is nice and interesting to see is that what we see in the clinical trials are being mirrored in the real-life data. And this is analysis from the US Medicare data, which has actually dabigatran in this data, around 64,000 patients in each group. And you see exactly what we saw in the trials. Less ischemic strokes with the blue is actually dabigatran, the red is warfarin, less ischemic strokes, less intracranial hemorrhage, improvement in mortality, in survival, and increase in the GI bleed with the NOACS as we saw in the clinical trials. So we move to registries, and there have been actually several prospective registries ongoing now, and actually collecting some very useful information for us. This is the Garfield AF registry that is prospective, 35 countries, more than 2,000 centers, for newly diagnosed AFib and patients with at least one risk factor for stroke. And it has a 5 sequential cohorts. And this is data from the first 2 cohorts, and actually gives us some information about what's going on, or it was at the beginning, where actually only 38% in average of patients who are at high risk for thromboembolism were getting anticoagulated. An interesting finding also is that people who have low score, 0 risk, actually there were 42% who were inappropriately anticoagulated. The more recent data from Garfield registry, which actually included the first 4 cohorts of the trial, now you're seeing that there's the percentage of patients being anticoagulated have gone from 57 to 71, and you can see that in red, the NOACs are actually constituting significant number of patients who are getting anticoagulated. The preferred AF registry, it's also a prospective registry in Central and in East and Western Europe, prospective. And if you look at the data actually from this registry so far, the adherence to guidelines have gotten much better. We have up to 80 to 85% patients who are at a high risk being anticoagulated, although we still have problem with warfarin, maintaining patients on warfarin with adequate control. 1/3 of the patients continue not to be well controlled with warfarin. So there are some important issues to discuss about the NOACs. We know that one size does not fit all, and that's why most of all the NOACs actually have more than the 2-dose regimen. And the main issue is kidney function, actually. Do we need to monitor levels? You know, some people may ask, well, if you have somebody who came with a bleed or a stroke, do I want to know the levels to see if my patient is over or under treated? But you have also to look at the pitfalls for measuring levels, because you have to take into account kidney and liver function and what time you actually draw the blood. And remember that in the trials, actually they used fixed doses and there were no blood level checked, and the trials showed us actually the benefit and the safety of those drugs. So you have to take those into account. So if we talk about metabolism and renal excretion of those drugs, dabigatran is the mostly excreted, 80%, followed by indoxaban, around 50%, rivaroxaban, 35%, and apixaban, 27%. We should also not ignore hepatic metabolism and people who are taking inducers or inhibitors for glycoproteins, P-glycoproteins, or cytochrome P450. They need adjustment in their dose. The Europeans and the Americans have some guidelines to reduce the dose in case of renal dysfunction, and I elected here to put the US FDA recommendations. Any patient who had very advanced kidney dysfunction, creatinine clearance less than 15 ml per minute should not be on those drugs. For the dabigatran, if you are between 15 to 30, you should reduce the dose to 75. This dose was not studied, but the Americans used that for patients with moderate kidney dysfunction. Rivaroxaban, between 15 and 30 ml per minute for creatinine clearance, you reduce the dose from 20 to 15. Apixaban is a little bit different. So you reduce the dose from 5 milligram twice daily to 2.5 daily. If you have a couple of those factors, age above 80, weight less than 60, or creatinine above 1.5. And indoxaban, if you have creatinine above 50 and less than 95, you use the regular dose of 60 milligram daily, and you cut it in half for creatinine clearance between 15 and 15 to 50. If you have to discontinue those drugs for procedures, they have short half-lives. For low bleeding risk procedures, you stop it 24 hours prior to the procedure and you resume 24 hours later. For high-risk procedures, you go and stop it for 48 hours before and resume after 48 hours. You know. For the dabigatran, because it's most one that is excreted renally, you have to be more careful. So if the creatinine clearance is more than 50, 1 to 2 days before the procedure is adequate. If it's less than 50, then you have 3 to 5 days to stop prior to the procedure. Now, in case of bleeding, you stop the drug, of course. They do supportive measures, and there are things that they can use in emergency situations, like activated prothrombin complex concentrate or activated recombinant factor 7. In case of dabigatran, it's dialysable. But remember, when you reverse things, you have the risk, of course, of rebound thrombosis. The antidotes or the reversal agents are coming. Actually, the first one for the dabigatran was approved by the FDA just this month, and it's a fully humanized antibody fragment. The factor 10A reversal agent still on trials, and there's another agent that actually blocked both in trials. So the reversals are coming, but again, remember, the use has two effects. You know, you may actually, we don't want to overuse them, but if definitely with a life-threatening bleed, they will be handy. Remember that it's not only kidney function, inducers and inhibitors for glycoproteins or cytochrome P450 need to be taken in consideration, and you have to adjust the dose for that. And actually, I would refer you to Hein-Hubakel article in August 2015. It's updated when it gives you nice information about the adjustment that you need in those drugs. I'll use the last 3-4 minutes just to briefly go on the current guidelines, and this is the latest from the ACC HRS-AHA guidelines. Of course, your decision should be shared with your patient when you want to start anticoagulation. It should be assessed based on risk versus of a stroke versus risk for bleeding. The CHA-VAS score should be used as your method to risk assessment. Patients with prosthetic valve, we said, should be on warfarin, but not on the NOACs. For CHA-VAS score 2 or more, you have the warfarin or the NOACs as first line, as a class 1 indication, both. Just go through other things. Renal function should be assessed for all patients undergoing treatment with the NOACs at least once a year, and if they have renal dysfunction, probably every 3 months. For CHA-VAS score of 2 or more and creatinine clearance less than 15, as we said, there is no role for the NOACs. Please use the warfarin. A CHA-VAS score 1, in the American guidelines, you can use aspirin, you can use anticoagulation, or use nothing. So it's actually class 2B indication where what you want to use. If you have end-stage renal disease or dialysis, you should stick with warfarin. And of course, as I mentioned above, mechanical valves, contraindication to use dabigatran or any new oral anticoagulant. The AAC guidelines, similar somewhat. I just want to emphasize one thing. In the European guidelines, there's no mention of aspirin at all. Aspirin is out completely. And when we're talking about preference between vitamin K antagonist and warfarin, they prefer the NOACs. So here, ladies and gentlemen, Mr. Chairman, I would like to conclude by saying that the ongoing registries have supported the results of the clinical randomized trials, showing that the NOACs actually is at least as effective and safer for patients with non-valvular atrial fibrillation. And the main effect really in reducing hemorrhagic strokes and intracranial bleed and hemorrhage. The adherence to stroke prevention guidelines in non-valvular AF, despite the fact it's not optimal yet, but definitely improving. Now, the majority of the patients who are candidates for the NOACs, of the patients who are receiving warfarin, are actually candidates for the NOACs. And given the drawbacks of the warfarin therapy, we are seeing more and more patients being started or switched to the NOACs. Advanced renal disease is the most important limitation for the use of those drugs. You should monitor kidney functions, adjust the dose, or avoid the NOAC completely with severe dysfunction. Now, there is no head-to-head comparison between the NOACs, and therefore your decision which one to use will depend mainly on your patient characteristic and some logistics that you have in your hospital, whether it's availability, cost, and also patient preferences. Warfarin is not dead. It's the only pharmacological option for patients with severe kidney disease. Patients who have been on warfarin for a long time with adequate control, if they prefer to stay on warfarin, I think there's no problem with that. You may be forced to use warfarin in case of the regulatory issues in your department or reimbursement or cost. And finally, again, valvular atrial fibrillation, there is no role for the NOACs at this time. And thank you very much.